minutes, but for now, I'm going to go ahead and turn it over to Leanna, who will give the next talk.
Well, good morning. I only have a half hour with you, so I'm going to jump right in and get started. First, a disclaimer, I'm the author and copyright owner of the SNAP, and there's no licensing fee for use of the SNAP family of measures for non-commercial and funded research. All other areas, commercial research, paid clinics, I negotiate an acceptable fee. And I mention this because I am going to talk about some SNAP results today. So the outline for the talk is I'm going to introduce you to our clinic, the Notre Dame Adult Assessment Clinic, who we are, what we assess, measures we use. And then my plan is to walk you through our standard assessment process, which includes traditional diagnoses, and then to show how useful it is to put the results into a high-top framework when trying to understand the person's problems as a whole. So I'm going to start with the referral questions and then cover the other areas that you see on the slide. And next, I'm going to tell you about the results of the assessment organized by the major domains that we assess, which are shown here, and then summarize those results by assessment domain and in some cases by measure. And then I'll take you through a step-by-step crosswalk of the results to the high-top framework and discuss how the high-top perspective facilitates understanding the overall case presentation. So who we are a practicum within our clinical program, and second and third year clinical psychological science PhD students do the assessment practicum in the first or second year of their practicum experience. We assess people from a community mental health center, from the Notre Dame community, mostly students, but some staff and faculty, and the broader Michigan, Indiana population. The measures we use, we start with a demographic questionnaire online, and then follow with a semi-structured clinical interview, which covers pretty standard history of various different domains, current symptoms, the context, the onset, the functional impact, and any treatment that they are currently in, if any. Many of our clients are not currently in treatment. For psychosocial functioning and disability, we use a battery of measures shown here, and I'll get into the details of those when I present the results. For cognitive assessment, we always give the WAIS and WIMS, and this is because we are not only a service clinic, but also a training clinic, and this is so the students can build up their experience for internship applications. For standard diagnostics, we start with the DSM-5 level 1 screen and follow with the mini international neuropsychiatric interview. I'll tell you more about the DSM later. The mini is a semi-structured interview that assesses 15 common mental disorders. We routinely give the MMPI-2RF simply because it's still the most widely used measure of personality psychopathology per nationwide surveys of practicing clinicians, so we think our students should be familiar with it. We give other dimensional psychopathology measures as needed based on the clinical interview, such as the SNAP for personality pathology. We give a couple of measures, including the ASRS for the many requests we get for ADHD assessment, particularly from our college students, referrals. They're having trouble in school, and so they think maybe they have ADHD. We find that they do have ADHD maybe 15% of the time. Usually it's anxiety, depression. And a couple of measures, including the one shown here, for an increasing number of requests for assessment of autism spectrum disorder. We also have measures of experiential avoidance, dissociation, and so on that we use on an as-needed basis. And in fact, we add measures to our battery just as needed when a client clearly warrants it, and we know of a good one, we add it, and then it's there for future use. So the particular case I'm going to present was referred from the Community Mental Health Center. The referral question was assessed for a specific learning disorder and wanted diagnostic clarification for a wide array of symptoms. Demographics, behavioral observations. The client was a 35-year-old white non-Hispanic woman with a 7th grade education. She was oriented, although her affect was somewhat blunted with minimal facial expression, gestures, vocal inflection. She had a family history of bipolar disorder by report, her mother and maternal grandmother. She also reported that her mother, when she was growing up, was verbally and emotionally abusive to her, belittling her, putting her down. And her father was largely absent. He worked 2 jobs and was extremely quiet and avoidant. She suspected that that's how he dealt with the mother's abusive behavior. She grew closer to her father after her mother died 3 years ago. Her current situation is she lives with her father, her 8-year-old son, and her brother. They're all supported by father's Social Security disability income. Education-wise, she said she was a slow learner, didn't really read well until about age 16, always struggled with math, and that she was ill-treated by teachers. They called her lazy, she said. There was no special education available in her school. Her mother tried to get her held back a year so she could build a better foundation, but the school said no, because the kids will make fun of her for being held back. But what happened was the kids made fun of her because she didn't do very well in school. She quit school in 8th grade due to increasing panic attacks and depression, and she had begun cutting herself for relief. Her social and occupational history: she had few to no friends in school. She occasionally would have a friend. They would make friends with her for a short period of time and then move on. She had few current friends. She basically had her family, some social media friends, and a few from her previous job. She had had a brief romantic relationship with another woman, but broke that off due to her partner's lying and cheating, and that was the only romantic relationship she'd ever had. She worked at Wendy's for 8 years and was fired for poor performance after she snapped at a manager when he criticized her. She was hired back for short periods of time, and when asked why she didn't try to get a different job, she said she preferred the familiarity, even if it was extremely stressful. And in both cases, she quit because she found the job overwhelming and extremely stressful, and so is currently unemployed. She's been on 5 different antidepressants since she was in 7th grade, currently an SSRI and an atypical antipsychotic, supposedly, according to her, for anxiety. And those are the drugs for those of you who are familiar with them. And she started psychotherapy for the first time last year and said she had never been assessed previously. Her current situation was that she was clearly severely depressed and anxious, and she had an extreme fear of criticism and negative evaluation. All of this ties in with her history traceable to the maternal abuse, teacher and peer mistreatment, lack of resources to help with any difficulty. She had to deal with things on her own. Her family was not particularly helpful. She was unable to go out alone. Her father would drive her to the clinic because she would get anxious, which would become a panic, and she essentially had developed agoraphobia. She said she preferred familiarity. Uncertainty and lack of control were her triggers for anxiety, and she used self-isolation to cope with this. This last bit was what first raised the possibility in our minds of ASD. These revelations of her having a hard time making and keeping friends. She said she had difficulty reading other people's intentions and that they had trouble understanding her. She didn't express herself well, she felt. Increased the likelihood that the autism spectrum was an element in her difficulties. Finally, she said she struggles with daily activities, paying bills, navigating bus routes, things like that. In terms of the psychosocial functioning and disability measures, she scored a 3.25 on the SFQ, which is a 8-item general functioning measure with 1 to 4. So the areas of greatest difficulty were finances and getting and keeping close relationships. She also had moderate to severe difficulty at work and at home, feeling lonely and isolated. She said she had difficulty enjoying any leisure time and getting along well with her family. On the HUDAS, these are Z-scores using community norms, mild to moderate impairment on activities of daily living, getting along, work, more moderate impairment in cognition, and severe impairment in social participation. On the satisfaction with life scale, which is a very brief 5-item scale, she scored 7s, highly dissatisfied on every question. And the Sheehan disability scale scored 0 to 10. Overall, she said her symptoms disrupt her life at an 8.3, a marked level, especially work, social life, with less impairment in family life. Here are her cognitive test results. The key points to note here is that her overall cognitive ability is in the low average range, with average verbal comprehension, borderline impairment in perceptual reasoning. These results suggest that she should have been able to learn to read far earlier than she did. And had she been able to read with otherwise adequate schooling in a more supportive environment, she likely would have been able to get through high school, or at least to get a GED at some point. In terms of memory, the results are comparable but trending lower than her general cognitive ability, with particular difficulty in visual memory and immediate memory. And this slightly better delayed memory suggests that if she can get information into her brain, she has some ability to retain it. Comparing these two sets of scores indicates that her memory was generally lower than expected based on her general cognitive ability. So that would be something to look into further if she were in treatment with you. There's a lot to take in on the Wyatt. We did this because of her lack of schooling. We wanted to get a current assessment of her achievement abilities. So I've highlighted the significant findings. Again, the total achievement was low average, commensurate with her general cognitive ability, but with notable difficulty in spelling and mathematics. The supplemental scales add notable difficulty in decoding and pick up again on orthographic processing being very low overall, particularly spelling. But again, the thing to note is the average and low average scores here, they're not in the markedly impaired range across the board. There are quite a number of significant differences between her overall score and her subtest scores. But you'll note that only mathematics has a positive value, meaning it's the only one that's lower than her overall score. So in all other cases, she performed significantly better on the subtests compared to her overall score: reading, decoding, basic reading, phonological processing, etc. So again, we may surmise that under other circumstances, she likely could have had an overall positive school outcome rather than dropping out in 8th grade. We use the DSM-5 level 1 screen to start the diagnostic testing. It's freely available on the DSM-5 website of the American Psychiatric Association, as are all of the follow-up measures should someone screen positive, meaning a 2 or higher. This slide lists the 14 areas that are assessed by this screening measure and the number of questions that each area includes. The different work groups put together these screening questions for their areas. So for example, the personality disorders work group put together the 2 personality disturbance items, which mostly are getting at criterion A rather than the traits, for those of you who are familiar with the alternate model of personality disorder. The follow-up measures are available for the areas highlighted here. Notably, they are all dimensional measures, and again, all freely available on the APA website. And here are the areas that the client screened positive. And as you can see, there are multiple mood and anxiety related disorders highlighted, somatic concerns, sleep, memory problems, obsessions and compulsions, dissociation, personality disturbance. So really a lot going on. For cognitive testing, we did, whoops, I think I skipped one. Yeah, there we go. On the mini, the semi-structured interview, these are the diagnoses that she met criteria. more than half of the 15 diagnostic areas in the interview. And then per cognitive testing, we did diagnose her with a specific learning disorder with written impairment in written expression and mathematics. So I mentioned we give the MMPI-2 RF routinely. And by the way, if you use the MMPI, I strongly suggest switching to the MMPI-3 now that it's out. It moves the MMPI another step towards being fully oriented toward factor analytically derived major dimensions of psychopathology, away from its empirical keying origins that were pounded into my head when I was a graduate student at Minnesota many, many years ago. In this case, we also give the SNAP because of the indication in the DSM-5 level 1 screen and her reported problems with interpersonal relations, plus extremely low self-esteem in the clinical interview. We gave 2 ADHD screeners because the cognitive testing had indicated some low attention and concentration problems. And we gave her the 2 ASD screeners because of her reported preference for familiarity and sameness. She reported sensory sensitivity. For example, she always wore the same clothes because she said that they were the only ones she felt comfortable in. She had was sensitive to textures. Her social interpersonal difficulties, rigidity, aloofness. Here's her MMPI-2 validity scales. Technically, this represents an invalid profile with extreme elevations on infrequent and infrequent somatic responses, high elevations on infrequent psychopathology, symptom validity, response bias. All of this indicates over-reporting, especially cognitive and somatic symptoms. But it otherwise seemed consistent with her clinical picture, and her variable true responding were more or less normal, particularly the true response set. So we went ahead with reviewing the clinical scales profile, keeping in mind the over-reporting. It's consistent with the clinical picture, again, starting with demoralization. The highest T-scores are on somatic concerns, depression, dysfunctional negative emotions, and aberrant experiences. Plus cynicism is just above the cut point, and RC 4 and 6 just below. Again, nothing really new here, just corroboration of what we'd learned in the clinical interview. The SNAP has a more normal validity profile, just deviance and back deviance, which is deviance measured on the second half of the test, because it picks up fatigue, for example, were elevated. And the overall index of invalid responding was right at a T-score of 50, right at the norm. This is the negative emotionality set of scales. It was elevated negative temperament, particularly mistrust. Manipulative and aggression were right at normal range, very high self-harm, high on both of its subscales, which are suicide proneness and self-esteem, somewhat high on eccentric perceptions, and dependence was also quite high. That was a new bit of information that we really had not gotten from the clinical interview. In terms of positive emotionality, 3 of the positively keyed scores were low, so very low positive temperament, low exhibition. She's very much hates being in the limelight, attention being paid to her, and entitlement underscores the low self-esteem. She's very low in entitlement. I don't deserve anything kinds of items, and very high on detachment. And I might say this particular combination of dependency and detachment is very bad for interpersonal relationships because it's keeping people away, but depending on them nonetheless. And this third group of disconstraint is right in the normal range, so nothing going on there. In terms of her ADHD measures, both current and childhood scores were elevated, but hyperactivity was higher than inattention. And this could be consistent with ADHD, but it also could be picking up difficulty paying attention due to anxiety, depression, and the hyperactivity could be related to her bipolar disorder. So definitive diagnosis requires additional information of the report, specific tests of attention, and we only screened for ADHD, so we do refer clients elsewhere if they want a definitive diagnosis. Same with autism spectrum disorder. Both measures scores were elevated, especially sensitivity, rigidity, aloofness, social anxiety. But again, these are screeners, so if they want a definitive diagnosis, requires additional treatment. So kind of a quick summary of the four areas that we assessed, sort of melding across the different psychosocial functioning areas. She had mild to moderate difficulty in basic self-care and household tasks, moderate difficulty in cognition and family life, and marked or severe difficulty in her social life and work, with a high dissatisfaction across the board. Cognitive ability, as I said, general intellect and achievement were low average, with particular weaknesses in perceptual reasoning, math, and spelling. Memory was lower than predicted by the general intellect and achievement, with particular weaknesses in visual and immediate memory. The DSM-5 diagnoses, in addition to the specific learning disorder, she had several different depressive disorders, several different anxiety disorders, and binge eating disorder. Looking at the self-report measures for personality and psychopathology, the MMPI-2 was marked by over-reporting, especially cognitive and semantic. The affective symptom dimensions, a lot of negativity, low positive emotions, mistrustfulness came out with the cynicism, and then the somatic complaints and aberrant experiences. In the SNAP, a similar picture, some unusual experiences was the main kind of over-reporting. Affective symptoms, again, negative temperament, low positive temperament, low self-esteem, and a greater picture of the interpersonal difficulties, in addition to the detachment and mistrust, which we saw elsewhere, also picked up dependency. In the ADHD and ASD screening, we saw the hyperactivity, but consistent with multiple diagnoses. ASD elevated on both measures, consistent with the reports in the clinical interview, and didn't seem to be other good explanations for this. So we suspect that somewhere on the autism spectrum disorder, but again, a definitive diagnosis requires follow-up testing. So putting the personality and psychopathology and DSM results together, affective dimensions from the MMPI, SNAP, and ASD suggests lots of difficulties in the negative temperament and positive temperament domains. And if you throw in the DSM, we've got multiple depressive and anxiety disorders plus binge eating disorder. Affective dimensions, high distress, low positivity, interpersonal relationships, difficulties here with aloof and detachment, mistrust, and social anxiety, cognitive sensory processing, the somatic sensitivity, unusual thought processes. And so boiling that all down, we've got the distress and low positivity, aloof, detached, mistrustful, hypersensitive, hyperactive. So now to high top. You've seen the high top figure. This is the full figure from a general psychopathology P factor at the top to individual signs, symptoms, and maladaptive behaviors at the bottom. We're going to be focusing on the middle layer, cutting off the very top and bottom, focusing on the spectra, subfactors, and the homogeneous symptom components and maladaptive traits that are in this arena. So the high distress and low positivity, if you put that into high top broadband spectra, gets you to the internalizing area of the high top. So this, one of the main domains, one of the main spectra of the high top hierarchy. If we add then low positivity, it adds the detachment domain over here. So we've got these elements to consider, as well as these elements to consider. So putting those together, we've got internalizing and detachment. If we add the interpersonal relationships, we don't get anything new particularly, we get the aloof, detached, mistrustful, also part of the detachment spectrum. Suspiciousness is part of the detachment domain. So the interpersonal and the affective domains go together, picking up both internalizing and detachment. Turning to the hyperactive cognitive sensory processing, we have the somatic sensitivity and unusual thought processes, and this broadens out then from internalizing and detachment and pulls in thought disorder and somatic form. So you can see the high top actually is quite well arranged in that it starts here, she had a little here, but it's really all together. There was a great question in the Q&A about why detachment is off over here rather than part of internalizing. And I think that is something that we are actually looking at, and that perhaps switching these two so that detachment is closer. The reason that it's here currently is that much of detachment grew out of the negative symptoms of psychosis with the flattened affect and so on. So detachment kind of has those two different arms. It's got more of an internalizing flavor and it's got more of a thought disorder flavor. So maybe it should be in between to reflect that that sort of dual nature of it. So these are the broadband spectra of the client's difficulties in high top terms. If we simplify it, the affective dimensions and interpersonal dimensions indicate the internalizing and detachment spectra, the hypersensitive, hyperactive somatic cognition, the somatoform and thought disorder spectrums. But we can also drill down into the subfactors and look at distress, fear, anxiety, eating pathology, mania, eccentricity. So we can get down to this level and see that the various more specific things about the client's psychopathology are addressed in high top. And if we go one more down to the component level, all of those internalizing and detachment spectra details are there. These are all from the client, all from the client's assessment that we do in a fairly standard kind of way, but they can all be organized into the internalizing and detachment spectra. Similarly with the somatoform and thought disorder spectra, these are all the client's different pieces, but they can all be found down here in the components of high top. If we zero in on just those components, you may be able to see a few of them. So there's the cognitive problems with somatoform, the negative relationships, here's panic, the dysphoria, lassitude, anxiousness, the suicidality, the GAD, low well-being, and then the hypomanic activation, hyperactive cognition, the eccentricity and unusual beliefs and experience, and finally the anhedonia and intimacy. So the question then becomes, would you rather deal with all of these different putatively distinct disorder, or think of it in high top terms where we've got internalizing and detachment with all of these components of sort of an integral part, and same thing with the thought disorder spectra. And I see I managed to use up all but 30 seconds of my time. So hopefully we'll have a little time at the end for questions, or we can take your questions in the chat or the Q&A and get back to you. And I want to thank you for your time and attention, and quit sharing at this point.
Hey, thank you, Leanna. So with that, will you pass it off to Dr. Nelson?
All right, so my name is Brady Nelson. I'm an associate professor at the Department of Psychology at Stony Brook University. So today I'm going to be talking about our training clinic's recent integration of the high top battery into our adult assessment cases, as well as a focus on 2 example case presentations. So a couple of things I wanted to highlight before getting into the case presentations, and none of this is going to be content that will be new at this point, but this did really heavily influence the way that we think about and utilize the high top battery within our clinic. So the high top battery provides a very comprehensive overview of psychopathology that can be discussed at both higher order and narrow levels. So at the higher order, you might talk about psychopathology at either say the spectra or subfactor level. But at a more narrow level, you might talk about it in terms of maladaptive traits and symptom components. Now, most of the measures that are included in the high-top battery were actually designed to measure either symptoms or traits and facets. And I'm going to talk about at least the CAT-PD in terms of traits and facets, although I know within the high-top model and how Len has talked about things, he's kind of distinguished them as kind of spectra and traits. So just, I say traits and facets, you can also kind of substitute it with spectra and traits. So most of these measures were designed not necessarily to measure these higher order dimensions, but really to measure these symptoms and traits. And so any discussion of the higher order, say superspectra, spectra, or subfactors, largely needs to be done based on your interpretation and integration of the measures. Now, the decision to focus on either higher order and or narrow levels might really depend on the client profile and or referral questions. So just as some hypothetical examples, in some cases, you might have clients that are presenting with more limited psychopathology. And so this might be someone who is presenting with a more focal depressive episode or a particular phobia. In this case, you might want to focus more on the maladaptive traits, facets, and or symptom components as it'll be most relevant to that client. Now, in other cases, you might have clients who present with a variety of psychopathology with notable areas of greatest severity. And so in this case, you might end up highlighting particular spectra or subfactors, but also emphasize additional narrow features of their profile that might be at the trait or symptom component level. And there might also be clients who present with very broad comorbid psychopathology. And in this case, it might be best to conceptualize them at either the super spectra or the spectra level. Now, part of what I will be discussing today is how we have utilized the high-top battery in the context of adult assessment cases. And while it is included along with lots of other tools and measures, we really begin to use it very early on in the assessment process, which is pretty much after they complete a phone screen with clinic staff, but before we even do an intake interview. But as has already been mentioned, these are not intended to be diagnostic in and of themselves. And so we're using these to, again, develop hypotheses about these clients. And then we are going to collect other information that can verify our hypotheses across other data, including interviews, other self-report questionnaires, review of medical or psychological records, as well as observations. And so the key thing I want to emphasize is that the high-top battery, I think, is best used in combination of both quantitative and qualitative aspects of an individual's profile. Two final points I just wanted to raise. One is that episodic symptom components or the presenting symptoms might be the emphasis of what initially brings someone in for an evaluation or brings them into the clinic. What we have actually found is that the maladaptive personality traits can also be very relevant as well and might help you to distinguish whether this is a more potentially recent onset, more time-limited set of psychological problems as compared to someone who has been experiencing problems for longer periods of time that may become to be more trait-like. And then finally, as usual, culture and development should always be taken into consideration when interpreting and using the high-top measures. Okay, so within our training clinic, which is the Krasner Psychological Center, what we use is a slightly modified version of the high-top DAT. So to assess symptom components, we are using the IDAS-2 as well as the audit and the DUDIT. We also supplement it with the Barkley Adult ADHD Rating Scale, as we do get a lot of referrals for ADHD evaluations. And then to assess maladaptive traits and facets, we also administer the CAT-PD. Other aspects of the high-top DAT that were measured in Catherine Jonas's presentation, we do not administer just for the purposes of they don't seem to be as relevant to the types of clients that we get into referred to our clinic. So what I'm going to be doing is going over two de-identified clients that came to the clinic for an adult assessment. I'm going to be presenting and primarily focusing on the high top battery and the scales as opposed to the comprehensive evaluation, because I want to talk about how we would potentially use this information at a very early time point in the assessment process. And so I'm going to present to you some just very basic information, which might be the limited information a clinician is presented with about a prospective client, and then to talk about their high top profile and how we might conceptualize and think about it. Okay, so client number one is a 22-year-old non-binary, assigned sex female, white undergraduate. They were referred for an evaluation because they recently withdrew from school due to exhaustion and feeling overwhelmed. And based on our brief phone screen, they reported a longstanding history of depression and anxiety that had an onset in childhood. They were also currently seeing a therapist weekly for CBT. So we had the client complete the high top battery online. And what I'm going to show you next are going to be their scores and profile. I'm going to start with the symptom components, focusing on the IDAS-2 as well as the audit and the DUDIT. And so what I'm showing you on the left are the different IDAS-2 subscales organized conceptually according to subfactors of distress, fear. I'm calling it bipolar here in ADHD. And on the right are going to be their audit and their DUDIT scores with the recommended risk level cutoff. And so all of these are the scores on the graph are T-scores, again, with a mean of 50, standard deviation of 10. And what we tend to do is to use between 65 and 69 as being considered at risk or borderline, and 70 and above as being in the clinically significant range. So what you can see with this particular client is that they are reporting elevations across a number of distress symptom components, including at-risk dysphoria, lassitude, low well-being, as well as clinically significant appetite loss. Now, in the fear subfactor, they are reporting at-risk social anxiety coupled with clinically significant checking and cleanliness. And there were no elevations on bipolar or ADHD symptom components. Across the substance use measures, they scored a 0 on both the audit and the DUDIT. And so we primarily use the raw scores of the audit and the DUDIT and the recommended cutoff, not necessarily for diagnostic purposes, but to inform us whether we need to do a more in-depth, thorough evaluation of drug and alcohol use. Okay, so with this client, based on symptoms in the last 2 weeks, we are seeing some at-risk and clinically significant symptom components across distress and fear. Now, we're going to look at their CAT-PD. And so with the CAT-PD on the left, what I'm going to show you is actually going to be the higher order traits, which again, Len referred to as spectra. And then on the right, I'm going to show you the lower order facets that make up each of those traits. And so what you can see is that across the higher order traits, or again, the spectra, you really only see one that is really kind of close to the at-risk range, and that is with detachment. Now, when we look at the more lower order traits, what you'll actually see, there are a number that actually are in both the at-risk and the clinically significant range. And these are primarily within the negative emotionality and detachment spectra. And so they are reporting clinically significant anxiousness and depressiveness, as well as at-risk health anxiety, and clinically significant anhedonia with at-risk romantic disinterest and social withdrawal. So what's interesting here is, despite the fact that on the last 2 weeks measure from the IDAS, they are reporting some depressive symptomatology that is in the at-risk range, when they're asked other questions that are getting at more trait-like aspects of psychopathology, we see clinically significant traits across depressiveness and anhedonia. Now, the high top DAT comes with a very nice manual that has descriptions for each of these scales. So I'm not going to sit and read these because you can read them on your own. But the point is to emphasize that within this client, you could use these descriptions to think about them at both a current symptomatology level, primarily emphasized here by appetite gain and OCD-like symptoms, as well as the spectra and trait level, primarily focusing on anxiousness, depressiveness, and anhedonia. So with a client like this, from a high top perspective, we could think about them and describe them at a maladaptive trait level as being characterized by depressiveness, anhedonia, and anxiousness. But we can also emphasize at the symptom component level, the checking and the cleanliness symptom components. And so this client completed then a more thorough adult assessment evaluation. And as we do with all evaluations, we still at the end give them a DSM-5 ICD-10 diagnosis. And so what this client ended up receiving as diagnoses were major depressive disorder, recurrent severe, as well as generalized anxiety disorder and obsessive compulsive disorder. And so you can see across the high top traits and symptom components that they do represent the dimensional features that seem to be core aspects of these DSM diagnoses. Okay, so just for one other case example, this was a 22-year-old female biracial undergraduate. She presented to the clinic because she was having difficulties with attention, concentration, motivation, and time management. And she had questions about whether she may have ADHD. She also reporting a long-standing history of depression and anxiety with the childhood onset, but she had no history of other psychological evaluations or treatment. So this is what her profile looks like across the INS2, the audit, and the DUDIT. And so what you will see is that across all the subfactors, including distress, fear, bipolar, and ADHD, there were a number of both at-risk and clinically significant symptom components. In fact, across distress, there's clinically significant dysphoria, lassitude, insomnia, appetite gain, suicidality, ill temper, and traumatic intrusions and panic. Across fear, we see clinically significant social anxiety, cleanliness and orderliness. There is even clinically significant mania and at-risk inattentive symptoms from the ADHD, from the BARS. Now, across the audit and the DUDIT, this client was reporting drinking and drug use that was in the, and I would call the low risk, but potentially problematic range. And so these were additional areas that required further evaluation. Now, when we looked at their CAT-PD profile, what we see is some continuity between what we are assessing with the IDAS as well as what we can assess with the CAT-PD. And so at the spectra level, you'll see that they actually had negative emotionality scores that were in the clinically significant range. And this becomes obvious when you look at the lower order indicators of that in terms of affective ability, anger, and so on. Nearly all of them are in the clinically significant range with the exception of health anxiety. Now, while none of the other spectra were in the at-risk or clinically significant range, within 3 of the other 4 spectra, you do see some lower order traits that were in the clinically significant range, including anhedonia, emotional detachment, non-perseverance, and peculiarity. So this is a client that is reporting both clinically significant symptomatology within the last 2 weeks, as well as both spectra and trait level maladaptive personality pathology across a number of different domains. And so with a client like this, from a high top perspective, we could describe them at a number of different levels. So at the spectra level, we might think about them as having clinically significant internalizing psychopathology. At the subfactor level, we might emphasize that they seem to present with primarily distress and fear psychopathology, although you could possibly also make a case for including a mania and thought disorder in there as well. Now, at the maladaptive trait level, nearly all aspects of negative emotionality were elevated, plus particular facets or lower traits from detachment, disinhibition, and psychoticism. And at the symptom component levels, they had multiple distress and fear symptom components, plus mania, as well as inattention. So, I don't think there's necessarily a right way to conceptualize and integrate this all together. Given that some of the information across different levels does overlap with each other, the way that we decided to largely conceptualize this was someone who's presenting with significant internalizing psychopathology, as well as some externalizing disinhibition, primarily characterized by non-perseverance as well as inattention. And so based on the comprehensive evaluation, this individual ended up receiving DSM diagnoses of bipolar 2 disorder, generalized anxiety disorder, social anxiety disorder, and ADHD inattentive presentation. But you can see how several of those disorders may really be better represented and captured by some of these higher order dimensions and levels that there is really lots of elevation across many different measures. So I just want to end with recommendations for how you might think about providing this type of feedback to a client. Much of this is probably going to be information that is already quite obvious and relevant to what you do. But this is just based on our early experience of integrating this measure into adult assessment cases and then providing feedback to those clients. So one is in the context of a measure like this, when we're using T-scores, it's always helpful to explain to a client what a T-score means. They can be confused at times, I think, regarding, what is important, what's not important, what's elevated, what's not elevated. So we tend to emphasize describing what a T-score is and to talk about these as being dimensional measures. What seems to work best is to focus more on patterns as opposed to explaining every score. So as an example, with the second client, there would be a lot of scales to potentially review with them. And I'm not saying you can't do that or shouldn't do that, but when you see lots of elevation, knowing that you may be emphasizing kind of higher order dimensions, it may be better to focus more on patterns as opposed to going through score by score. We found that this can be very useful for validating what clients are reporting in a very unstructured interview or based on your observations. So clients are coming in and telling us what they're able to tell us, and we're able to validate, these clinical concerns based on these types of measures. It also is really helpful to highlight other areas that might initially be ignored or not discussed. So again, with the second client that I presented, this was initially a referral for a suspected ADHD. And as you can tell, there was a lot of other psychopathology that became really relevant to their profile and their presentation that may have been overlooked had we just focused in on just evaluating ADHD. From a conceptualization perspective, I do think it's important to at times distinguish between the trait and the duration specific measures. I found that at times this can be helpful in getting an early insight into whether someone might be presenting with possibly more new onset or time limited psychopathology as opposed to more chronic or long-standing psychopathology, which might have more important implications, not only for conceptualization and diagnosis, but also treatment. And as usual, it's helpful to not avoid discussion of challenging areas, particularly when assessing things like psychoticism and antagonism, and to make sure that those are discussed as part of conceptualization and feedback for that client. Okay, so I think that is the end for me, and I hope that leaves us time for some questions.
Hey, thanks, Brady. Yeah, I do think we have time for a few questions. Let's see, there was a question about ASD's symptom placement within high top structure and whether you could elaborate on that.
Yeah, that's a good question. We are in the process of looking at essentially every symptom in the DSM, so we can categorize a wider variety of types of psychopathology in the entire high top. I see ASD in a couple of different areas. Definitely in detachment would be one area, and depending upon the particular person's clinical profile, it might also be in somatoform, and certainly there's elements of thought disorder. So it's not a unitary diagnosis that would fit into one particular spot. That's, again, in some ways a strength, and some people would say a weakness of high top, is that it breaks apart DSM disorders into their different components. But I would look first in detachment I think that would be its primary home.
I can just say one thing based on some clients that have been referred to us for autism evaluations, in addition to some of the other things that I covered. What we have tended to do is we actually supplement this evaluation with a more in-depth evaluation of autism spectrum pathology. So it might start with something more basic in terms of a self-report or a parent report, SRS2 or SCQ. But if there is suspicion that autism may play a role in their presentation, we actually supplement the evaluation with an ADOS2, which is, a very specialized assessment and time-consuming. But we do have the capability of doing that.
Yeah, that's the one where I said that we refer out. There's a local clinic that does that. We don't do it ourselves because we're a very small operation. Not connected with the medical school or anything. It's just me.
And there's a question about scoring the measures that came in during the previous talk. And just because Catherine's not here to answer that, I can answer for her. And that if you email her, she can send you either a Qualtrics or a REDCap version of the scales that automatically scores them and provides you with a printout of the scores. So it's really pretty easy to do for clinicians and for students working with them.
As well as the normed scores too, which is really helpful for clinical cases. And so you do get the T-scores based on the scoring tool.
The other questions also came in during the previous talk, but I think they're relevant here too. So maybe we can give that a try. There's a question of, are there other empirically supported psychological constructs like traits, processes, function states not currently specified in the high-top model that show promise to enrich the model if added? For example, specific executive and cognitive functions, temperament, regularity, sensory threshold, theory of mind, and so on.
Yeah, definitely. And as I said, we're in the process, particularly led by Mary Forbes, working on examining where the entire set of DSM-5 symptoms fits. There's a process also for revision of the high-top model. One of the issues is, at this point, is the requirement of a firm empirical basis for addition. So we don't just add things by saying, I think theory of mind fits here. But yeah, definitely there are a number of things in the works. What were some of the specific ones again, David, that you mentioned?
Regularity, theory of mind, literality.
Yeah, and anybody who wants to propose an addition to high-top, there is a process for that. If you get on I imagine if you get on the high-top website, I'm actually not sure where the form is, but if you have data that would suggest that a particular measure or a particular construct would fit in a particular place in the high-top model, or that the high-top model needs some revision in order to include something, we have a process for that, and really want high-top to be a living document and not a static form that only gets changed once every 15 years, like some other nosologies that we know, but that it's responsive to data. So yes, nothing imminent, I should say, but yes, in the works.
Yeah, and anyone can suggest a change to the model. It doesn't have to be someone affiliated with high-top in any way.
Absolutely.
We encourage that from anyone who's interested.
Absolutely.
Another question that might be relevant here is, in a clinical setting, how would you suggest balancing the elevations of certain high-top dimensions with the reason for seeking treatment and their presenting problem? In other words, how would you still incorporate the high-top dimensions into treatment if their primary concern for seeking treatment is largely unrelated?
We have not generally found that to be true, unless it's an issue of what I call the ticket and the target, which is that people often come in with their ticket in the door is, this is my presenting complaint, this is what I'm concerned about, but it's really just their ticket into the door. The real problem is something else. And so we have generally found that with a good feedback session after our assessment, the clients will often admit to the issues that were revealed on the assessment as being a major part of why they came in. But sometimes it's stigma. They don't want to say that. Sometimes it's fear that they have X, Y, or Z. So they present with something else to get assessed. But we try to explain that the assessment is nothing magic. They give us the information. We just organize it. And so when we feed it back to them, it resonates with clients and they can see it from our perspective. One example that I have recently, I actually don't remember what the presenting complaint was, but we found the person had a trauma history that she had not mentioned initially, and were able to tie a number of her current difficulties to this trauma history. And by the end of the feedback process, she had fully come around and was ready to jump into trauma-based treatment. And she said she was feeling better already as a result of the assessment and making sense of her experiences in terms of the trauma, which she had been trying not to do. She actually had been avoiding it. So that's been our experience.
I could give one just other experience on our end that seems to happen not frequently, but more frequently than not. And we do get a number of referrals for suspected ADHD are individuals who present with problems with attention concentration, memory, academic problems, present to the clinic. They have high average to superior, working memory and processing speed. They're reporting every ADHD symptom you can imagine, but they also have this long history of depression and crippling anxiety. And so it's very easy because we're still answering the referral question, which is why do I have these problems? What's contributing to my academic dysfunction? But we're doing through a lens that is more shades of gray and more comprehensive, as opposed to just saying to them, no, you don't have ADHD, which is sometimes what they think they're going to hear, but it's more about painting a more nuanced picture of what they might be experiencing.
Yeah, we have that exact same experience. And as I said, I would say about 15% of the time at most, they actually do show an attention problem and are able to use that through our disability services and get some accommodation. Most of the time, it's more concentration problems due to anxiety and depression.
Yep.
But you're right. That's a good way to reframe it, is that we are answering the referral question, just not in the way that they expected or wanted. And, most of the time they're actually relieved. Occasionally they'll be disappointed that we can't just refer them and they'll get a pill and everything will be better. We try to explain that, a lot of people would do better on a little bit of speed, but that's not a long-term solution to your problem.
Now, a question for Brady: How do you explain your assignment of both high top and DSM diagnoses when giving feedback to clients?
Sure. So, we emphasize the kind of the quantitative aspects of their profile within the context of a descriptive narrative. So, we want to talk to them about that there are psychological profiles of which people have these things to different degrees. And that's kind of the primary way that we want them to think about what this evaluation can tell them. We also acknowledge that some of the world works in dichotomies and works with diagnoses. These might be necessary for accommodations, for reimbursement purposes, and so on. And so we provide these because they still are a part of the kind of medical model and technical terminology that people use. So to us, it provides an opportunity to say, you are not just someone who has depression. You have a number of features that are of clinical significance and relevance. But sometimes in certain situations, we need to come up with these diagnostic labels for these other purposes. And so, we try and connect them together so they can see how they're related, but to know that one might be used in one situation versus the other in a different situation.
Yeah, we do something very, very, very similar. And that's kind of what I was trying to show in my presentation, how High Top just rearranges things in a way that's actually simpler.
Yeah, and the high tab feedback has, I think, gone very well because it in many, not every, but in many cases, it really does validate to clients that I'm not making this up, I'm not crazy, no one believes me. We can validate this and to talk about, you do have a number of problems. Some of them are much more severe and more prominent. Others are also of relevance that maybe don't need to be the first line of attention. And it provides a much more nuanced picture as opposed to giving them 5 diagnoses and having them wonder, what does this mean for me?
Exactly.
I'll save we didn't get to all the questions. I'll save those questions and pass them along to the presenters tomorrow. I think some of them can answer them. There were a couple of questions related to things like the IDOS and the CAT PD. Len gave his contact information in his talk. I'll also pass that along either through email or through the chat tomorrow. They might be better questions for him to answer directly. And I just want to thank
I'm happy
everyone.
to have my email shared too, Camillo. You have it. If you want to share that in the chat, that'd be great.
Me too.
In fact, someone already looked it up and sent me one email.
Okay, great. So thank you everyone for coming, and we'll see everyone tomorrow morning.
Thanks for organizing.
Sure.
Bye.
Bye, everyone.